Good afternoon, everyone. I'm Ben Butkus, Editorial Director for GenomeWeb, and I'll be your moderator today. The webinar is entitled Making More to Guess Less, Comprehensive Immune Profiling for Immunotherapy Selection. This webinar is OmniSeq. Presenters today are Marcia Eisenberg, Chief Scientific Officer and Senior Vice President, Laboratory Corporation of America; Morrison, Founder and Chief Scientific Officer, OmniSeq; Shumei Kato, Oncologist and Assistant Professor of Medicine at the University of California, San Diego, Moores Cancer Center. Our new attendees, type in a question at any time during the webinar. You can through the control panel, which usually appears on the right side of your screen. Q&A box in the upper right side of the control panel. When you click on Send To, please select all panelists. We'll ask the panelists questions after their presentations. Begin with Marcia Eisenberg of LabCorp. Please go, Marcia.
Thanks, Ben. So what I'd like to talk to everybody about today is LabCorp's integrated oncology business's involvement in companion diagnostics, the evolution of the immuno-oncology landscape, our experience in PD-L1 testing, why there is still an unmet need in diagnostics to support immuno-oncology clinical decisions. Started, I'd like to just provide some context to the perspective that LabCorp has regarding clinical decision support in oncology. LabCorp is a very large national reference lab. We process over 400,000 specimens a day with slightly over 1 million test results a day. We have over 30 different clinical disciplines, and we have specialty testing groups. Our integrated oncology business is a footprint that focuses specifically on patients living with or facing a diagnosis of cancer. We have 4 different sites across the U.S., and in this business alone, we see approximately 250,000 patient samples a year for oncology-specific assessments, which includes molecular testing, and companion diagnostic testing. Oncology and LabCorp, which continues today with the acquisition of Covance. We had a very long history supporting the development and commercialization of companion diagnostics in oncology. Our history dates back to what is truly the first companion diagnostic in oncology, with the validation and the launch of the Hercept test for the use of Herceptin in breast cancer patients. We were the first lab to broadly offer EGFR testing, and we played a role in the analytical and clinical validation studies for several companion diagnostic tests, which includes PD-L1 by immunohistochemistry for nivolumab and pembrolizumab in non-small cell lung cancers. I think this gives us a unique perspective on the evolving landscape of immunotherapy and the associated diagnostics. Just a little bit and talk about recent developments in the area of immuno-oncology, in particular the PD-L1 checkpoint inhibitors. The past years, in 2017 in particular, have seen a dramatic increase in the number of PD-1 checkpoint inhibitors that are on the market, as well as the number of indications. Opdivo and Keytruda lead the way here with 8 and 7 indications respectively since 2014. As illustrated in this chart, there are very active late-stage development efforts across most of the major oncology indications. and it's estimated that more than 300,000 patients in the U.S. will be eligible for checkpoint inhibitor therapy by the year 2021. And approvals of the checkpoint inhibitors, we've seen the approval of several companion and complementary diagnostics. What's notable is that each of these therapies has been tied for the most part to a separate assay, and to make things even more complex, each assay and indication has its own scoring cutoff. There have been relevant approvals lately, relevant to today's discussion and the state of testing. Obviously, there's PD-L1, which we'll talk a bit about today in more detail. The use of PD-L1 assays has shown that patients can be stratified for response based on having high levels of expression. Another tool that we recently saw, and the first time, a therapeutic was approved across all tumor types based on the presence of a genetic marker. The microsatellite instability, MSI, or match repair deficient tumors. The data in Keynote Z16, specifically the study here, shows the presence of MSH high or mismatch repair deficient tumor status correlated to substantial response in patients with colorectal cancers as well as other tumors. PD-1 has been the main biomarker that's been available for widespread use to support the use of checkpoint inhibitors. The fact that multiple assays for the measurement of the same biomarker has created consternation and confusion and complexity in the medical community. The following slides will highlight how some of the different tests have compared. This is presented at ASCO in 2016, which was based on our early experiences with the two PD-L1 immunohistochemistry tests that were available at the time, the 22C3 PharmDx IHC and the 28A IHC. Was that there was a similar pattern of expression at the various cutoffs, but the effect that initial cutoffs would have had on the portion of tumors that would have been considered positive or high expression because of the difference in the cutoffs. A comparison project, which published the first phase of its findings earlier this year, is shown here. They evaluated the staining of the 4 PD-L1 clones on 39 samples. Each was individually scored for the percent of tumor cell and the percent immunocell expression of PD-L1. The graph is the distribution of the mean score from 3 pathologists for each assay on each case. No diagnostic cutoff was applied. The bit-colored curves allowed comparison of the scores that ranged between the 4 assays. The analysis of this cohort was that 3 of the 4 assays were closely aligned on tumor cell staining, whereas the 4th showed consistently fewer tumor cells that were stained. So far in our discussions is that there's PD-L1 tests. They perform slightly differently. There are different drugs. And add to the complexity and the confusion is the distinction between a companion or a complementary diagnostic. The main drugs that are available today, one has PD-L1 testing as a companion diagnostic, that's Keytruda, and defined most recently by the FDA, though this language is still in draft. The diagnostic is a medical device which provides information that is safe and effective use of the corresponding drug or biological product, and it is a necessary test before the drug is provided. And for Opdivo, the other most common checkpoint inhibitors, is complementary diagnostic. So this is defined, at least at this point in time, is a biomarker which defines a subset of patients that have a different benefit risk, but it's not a prerequisite. The test is not a prerequisite for receiving the therapeutic. Use of checkpoint inhibitors expands, and the promise of better outcomes for more patients is pursued. It's important that we keep evaluating tools that can identify the patients most likely to respond to these innovative tools. A couple of slides, I want to talk about the need to do that in some areas that we should be looking at. I think we can understand and conclude that checkpoint inhibitors have truly made a significant difference in the lives of many patients that prior would have been looking at very, very poor survival rates. But these advances, we still see that the response rates, for the most part, are still below 30%. Of these therapies range now into the hundreds of thousands of dollars per year. And with 1,000 clinical trials in immunotherapy or combination immunotherapy, we should be finding better ways to identify the best responders as well as those likely to benefit. And I do add to that the complexity of the state of the testing environment that we have to date, again, just adds to the situation that we find ourselves in. So the comprehensive biomarkers in the area of immunotherapy, clinical decision support, as well as clinical drug development has spurred efforts to formalize the landscape and the potential utility of these biomarkers. The Society for Immunotherapy in Cancer formed the task force to address this need. You can see the result of the consensus approach, which details a list of technologies and biomarkers and how the results could be used to potentially assess whether or not a tumor would be immunologically responsive, and one could potentially build a therapeutic strategy based on these results. But as a national lab provider have been looking for is a way to help address this unmet need, to look for these additional ways to pull them together for treating physicians, to help them build a strategy supported by tests in a clear and concise way. And I think that that's what led us to OmniSeq. And what I would like to do now is turn slides back over to Ben so that we can hear from Dr. Morrison. Thank you.
Marcia. Our two attendees, you may type in a question at any time during the webinar. You can go through the control panel, which appears on the right side of your screen. Continue the webinar with Carson of OmniSeq. Go ahead, Carl.
Dan and Dr. Eisenberg. A real brief overview of OmniSeq. We are a molecular diagnostic-based laboratory in Buffalo, New York. We're a subsidiary and original spin-out of Roswell Park Cancer Institute here in Buffalo, New York. We have had a strategic partnership with LabCorp Integrated Oncology, and they are exclusive distributors for our products. I'm going to give you a little bit of detail about that really are comprehensive profiling, one being genomic and the other being in-based. To any depth in those two assays, I want to just take a brief to our readers understand the difference between profile versus for targeted therapy versus profiling for immunotherapy. I think the fusion around that out in the field today, but we view these as distinctly different, and for many reasons, but primarily at the top of that reason is that targeted therapies are typically based upon the analysis of a single gene, mutations or copy numbers or translocations for that single gene, and a drug that uniquely fits into a lock and key of a variant for that gene. It's often comprehensive that you have to measure multiple genes. You have to use multiple modes of a bioinformatics analysis for the comprehensive approach. It's just one gene at a time, then spread to a very large scale. Immunotherapy is totally different, right? We know there are many, many moving different parts, both the host and the tumor, things that are impacting the outcomes and responses. And as we walk through this, I will show you that make more to guess less is really what we're trying to do in immunotherapy. And I'll be putting more emphasis today on immunotherapy. I am comprehensive genome profiling. We do an assay out there, OmniSeq Comprehensive, 144 genes. It's AmpliSeq technology, which is extremely robust. You know, we only have less than 2% failure samples that reach the laboratory. And it covers all the actionable genes that were out there today. But what I concentrate on is this product that we've recently immune report card. So there's, a CLIA-certified, New York State approved assay that's used in clinical use, right? It is the first comprehensive immune profiling assay out there today. So it measures much, much more than PD-L1. Not only does it measure more than PD-L1, when it does measure, it measures very accurately in a different way than the subjectivity of immunohistochemistry for a single marker. It really does this using 5 different tests to interrogate immunotherapy options. So while I look at genomic profiling, while that informatically is a fairly complex assay, when you do comprehensive immune profiling, not you interrogating the comprehension of it and the complexity of next generation sequencing, you also have to use many other modalities to confirm and also provide additional evidence beyond just the quantitative analysis you can get from next generation sequencing. So as we walk through this, you'll get the understanding, right? This really is 5 different tests that are just integrated into one approach. But the concept is that the physician and both patient can get their optimal met for the of therapies in one assay, and they're not moving around through 5 or 6 different tests to try to put together something that's not integrated. It also includes standard biomarkers and expression of 54 specific immune markers. Into some of the details of these later, not every one of them, but they're very therapeutically aligned. So when we're thinking about checkpoint inhibitors, we have to understand that there's a whole second or third wave of immunomodulatory immunotherapeutics that are beyond PD-1 axis inhibition, things like LOG3 antagonists and agonists and ICOS agonists and so forth. And we'll talk about those later. Often associated in a clinical trial with a PD-1 axis inhibitor. So it's many cases that are PD-L1 positive, whether it's by immunohistochemistry or RNA-seq analysis, still fail the first or third line treatment with PD-L1 or PD-1 axis inhibitors. And therefore you have to say, well, it's probably worthwhile considering how do we interrogate these additional immune markers to get the patient on the next best after PD-1 inhibition. The other thing I want to put together, and I will talk about it, right, that mutational burden, while it's often associated with genome profiling, really belongs over in the immunotherapy world. That's what we're using it for, right? Mutational burden is not about one specific gene. It's about how do we analyze hundreds of genes at one time and come up with this baseline so what the genomic instability is in the tumor. You have to get beyond just, you have to get into tumor infiltrating lymphocytes and then put that together with this T-cell receptor signaling, which really relates back to, in many ways, what is the type of immune response that both the host and tumor are presenting. Coming back to this concept, right, that there is an axis of the cycle of immunity here that if you break this down in the most simplest form you can put it into, it really starts with mutational burden and the release of cancer antigens within are primed and activated within lymph nodes and trafficking of T cells into tumors through endothelial cells And finally, then you get this interaction of the cancer cells and the tumor-infiltrating lymphocytes, and then hopefully in the end, the killing of the cancer cells. But with all that together, you realize you really have to measure at least 3 basic elements to do comprehensive immune profiling. 1, mutational burden, tumor-infiltrating lymphocytes, and 1, T-cell receptor signaling. And the immune report card is for mutational burden measured. We use NAC. We measure full exon sequencing of greater than 400 genes. We do MSI. MSI in many ways is mostly a surrogate marker of a high mutational burden, although I still think there's out there to be guided to say there are cases of MSI that do not have a mutational burden that likely respond to checkpoint inhibition, and is it a mechanism or is it a surrogate marker? But under infiltrating lymphocytes, we measure those by RNA-seq and also by immunohistochemistry. I'll give information later on of why we both RNA-seq and immunohistochemistry. And then under T-cell receptor signaling, which is the most complex part of this, we use 3 modalities: RNA-seq, FISH, and immunohistochemistry. And one of the most important things that we're trying to do, right, going back to the title of this talk, measure to guess less, right? So everything that we measure twice, right? We mutational burden twice, we measure tumor-infiltrating lymphocytes twice, and we measure the T-cell receptor signaling in 3 different ways. And the next here will show you some of the details how we actually do this. But if we start at the top of this, we have the RNA-seq analysis, validated 54 important immune markers by RT-PCR, the correlation with RNA-seq as well as immunohistochemistry, and divided that set of immune markers into those therapeutic development and have a direct drug target and that do not. We'll get to that later at the end of this presentation because it's very clinically relevant. And as we move around RNA-seq, well, let me stop a minute and say, too, in RNA-seq is a perfect place that we can compare the PD-L1 measurement by RNA-seq to immunohistochemistry for PD-L1 and turning into a more quantitative analysis. It also gives us, but you have to put both of them together because, you know, frequently I see cases where if we look at the tumor proportion score, which in PD-L1 immunohistochemistry owned by the neoplastic cells, if the RNA-seq, and say that the tumor proportion score is very low or 0, if you look at the RNA-seq analysis, you'll often see a moderate high value. And if you can look at the slide, you see there's lots of immune cell staining. I think there's been some detail around that, but you have to put the 2 together. You just can't say one and not the other to know accurately how to measure it. So patient burden, as I was saying, we do full sequencing for 409 genes. This is really the cancer gene census. We don't look behind this to say who's EGFR and who's KRAS. It's the mutational burden that's the important point for immune profiling. And MSI, today we're doing this by DNA mismatch repair deficiency by PCR. It's still sensitive and has the highest specificity of any test out there on the market. In the next year, there will be enough evidence to know how is MSI just a surrogate marker of mutational burden or a mechanism to itself. This is one maybe you've not heard a lot about, but PD-1 and 2 is amplified very frequently in Hodgkin's lymphoma, and it's for the very high response rate there, sometimes greater than 50%, sometimes up to 70% of these cases with PD-1 axis inhibition. So what we started doing PD-L1 FISH for solid tumors, and we have a small subset of solid tumors that are PD-L1 amplified, much higher than ALK and ROS1 and RET across multiple disease types. So that's worthwhile measuring. There's still a lot of need out there for validation of that data. What does it mean? We recently published a paper around urothelial carcinoma and amplification of PD-L1 and 2. This is also amplification of JAK2. All these genes reside like in a 5 million base pair amplicon there at 9p24. There's a lot of evidence out there being published today about PD-L1 and 2 amplification. We do cases with PD-L1 and 2 amplification that do not overexpress PD-L1. So you have to put it all together. You have to put the immunohistochemistry, the FISH, the RNA-seq analysis, the concept of measuring more to guess less. And then immunochemistry. Why do we do immunochemistry? Because certainly we do PD-L1 immunochemistry, and we use various clones that are specific to the subtype of disease that we're measuring, like you would use 22C3 for lung and 28A for melanoma, and so forth. One of the more valuable things we realized is tumor-infiltrating lymphocytes. So you can measure those very accurately with RNA-seq analysis and know exactly how many CD8 positive T cells and FOXP3 positive T cells you have in your tumor. But what we can't tell is what is the qualitative aspect of that. Because we have found that's very important in predicting response to checkpoint inhibition, and we're going to have a paper about this in the next month or so, right? It's just the number of T cells. It's enough T cells that are important. So again, we're measuring, CD8 and T cells in multiple ways, and we identified at least 4 patterns that we know are important. One referred to as minimally infiltrating and moderately infiltrating and strongly infiltrating. One pattern that you've probably heard a lot at the various meetings called excluded or non-infiltrating. We found it to be about 10% of all cases. Strongly infiltrating is also that's a minor subset of 10% of or more or less. And then moderately and minimally constitutes the majority of cases, but qualitatively measuring how cells are invading the tumor in a straightforward fashion, a lot of utility in predicting response for checkpoint inhibition therapy. That not only you have to have qualitative aspects of this test, you have to have quantitative aspects to your test. So I think many people think about comprehensive immune profiling. The first question they come to is, well, why don't you just use the whole transcriptome? Well, there's reasons for that, but first and foremost, at the top of the list, right, is the whole transcriptome sensitivity for low expressors. And what is at the forefront of low expressors is interferon gamma. So if you have to know what your interferon gamma response is tumor, and it's really tough to do that with the whole transcriptome. And there's a multitude of other markers that we've shown here that you can do, that you can have greater sensitivity for low expressors. It's important to use an FFPE-based approach or a targeted panel approach for doing immune profiling. The other to address here too is sensitivity and dynamic range. This is information that was presented at ASCO last year, showing that the seq analysis using the AmpliSeq technology that we utilize for immune report card, it has a better sensitivity and a better dynamic range than the leading competitor, which is NextRig platform. The kind of the medical concept behind the immune report card. There are 3 basic assumptions that you have to really utilize to understand the clinical utility of the immune report card. At the top of that is the basic assumption that the overexpression of a drug target is associated with response to that agent. That's true for every progression. It's not true for every drug target. It's true for many, many important drugs and targets that we've learned over the past few years. HER2, Herceptin, PD-L1, and pembrolizumab and nivolumab. With many key examples of this, I think we have many more to prove, right? I think there's some data at ESMO about log-3 overexpression and response with log-3 antagonists. I think this will become it's a blossoming field in immunotherapy. But that's the first assumption. Second assumption is you have to have a reasonable, objective method to determine overexpression of the immune targets. So a quantitative background for measuring expression of immune targets, RNA-seq, you have to understand that when you see these results, they're just a series of digits and numbers, right? And what you're doing with those. The first thing you have to do, and that was one of the foundations that took a year to develop, is called a reference database. So we developed a reference database of several hundred samples of OmniSeq data, many tumors, some that were treated with checkpoint inhibitors and some that were not. But the tip is when you test a patient, then you take their results and drop them into the world of all other patients and say, does this patient compare to several hundred other patients? And you rank their expression of PD-L1 or log-3 or ICOS or CTLA-4. And then from that information, you can compare that to someone as if you're measuring height. If you had the shortest person, the tallest person, and the person you measured was equivalent to the person you had defined as short, then you know it's a short subject. So that's the second assumption. The third assumption is that combination immunotherapy results improve response and survival compared to targeted therapy and monoimmunotherapy. I think proving this out, I think it'll take at least another half of a decade to prove out what combination immunotherapies work better than other combination immunotherapies. But the sufficient information out there today that's already showing some of these immune escape, like Adora 2A and CD39, and tests have a lot of value, particularly when combined with the PD-1 axis inhibitor. When patients fail PD-1 axis inhibition, what's the next step for them, right? Well, we think that the next step is enrolling them in one of those 800 or more combination immunotherapy trials that are available today. I also think that there's a rational approach to doing this. It's not just putting a patient on a trial without not knowing something about their tumor. Look at this slide here, and we go back to that cycle of immunity, where there are numerous genes here that are the targets of immunomodulatory immunotherapeutics. And if we measure them, and if we know someone has a very high expression of CD40, then it makes sense to give that person a CD40 agonist. If they have a very high expression of log3, we know it only makes sense to give them a log3 antagonist. Think through this more, right? If someone has a very high expression of a ligand that's associated with T-cell priming, such as OX40 ligand, it would make no sense to put that person on an OX40 trial because they have the pharmaceutical equivalent of that and it's in their blood. So what we can prove out here, right, is that there's a rational approach in all these patients on these 800 to 1,000 combination immunotherapy trials that are on the market today. There's this one spectrum where people would say, well, how do you know that these patients express these markers? Well, we have looked into our reference population. We realize that at least one half of the population is not mutation burden high. They're not PD-L1 high, and they're not PD-L1 and mutation burden high combined, right? That they express at least one of these markers that's associated with an agonist or an antagonist for combination immunotherapy. And over here on the right-hand side, we've listed 15 of the most common overexpressed immune markers that we have noticed in our reference population. So, right, measuring guess less, we have recently published analytically our assay immune report card in the Journal of Molecular Diagnostics, and I hope I realize it's a very high bar, and hope you enjoy reading this over the next month. And I'll turn this back over to Ben, and thank you, Ben.
Thank you, Carl. Or to attendees, you can a question at any time through the control panel, which usually appears on the right side of your screen. We'll now do the webinar with Shumei Kato of the UC Morrison Center. Please, Shumei.
Thank you for your time and opportunity to discuss the next generation immuno-oncology with personalized immunotherapy approach. My name is Shumei Kato, I'm a medical oncologist at UC San Diego Morrison Cancer Center. Close. Along with progress in the immuno-oncology field, we now have multiple checkpoint inhibitors that are FDA approved for multiple cancer types, including PD-1 inhibitors, PD-L1 inhibitors, and CTLA-4 inhibitors. Checkpoint inhibitors do occasionally have salutary effects with tail in the curve. The response rates across cancers remains to be about 20%. Multiple clinical trials are ongoing, trying to get other checkpoints or immune markers, especially in combination with existing checkpoint inhibitors, to achieve better clinical outcomes. Our challenge is to understand which combination we should choose to optimize the immune effect. As you see here in the table, there are numbers of targets we can think of, and this is far from the complete list. Look up the clinicaltrial.gov for immunotherapy combination. There are more than 200 ongoing trials. So the question is, which combinations we should be choosing for our patients? strategies are already being investigated. One example is a study with anti-PD-1 inhibitor nivolumab in combination with anti-CTLA-4 inhibitor ipilimumab in treatment-naive advanced melanoma patients, mentioned by Dr. Morrison. The randomized patient into nivolumab alone, ipilimumab alone, into the combination of nivolumab plus ipilimumab. You can see in the Kaplan-Meier curve in the left, the combination had numerical improvement in 3-year overall survival, 58%. But nivolumab, which had 50% and 34% for ipilimumab alone. Response was also better with combination approach. However, stratified based on the PD-L1 status among patients with PD-L1 expression more than or equal to 1%, combination approach with nivolumab and ipilimumab has similar overall survival outcome when compared to nivolumab alone. Suggest treatment with nivolumab alone would be for this patient population. On the other hand, with low PD-L1 expression, which was defined as less than 1%, combination of nivolumab plus ipilimumab had numerically better overall survival when compared to nivolumab alone. Although the result was not statistically significant, it suggests some patients may be benefiting from the combination approach. However, it's important to note that, not surprisingly, patients who received the combination therapy experienced more adverse events. So, several lessons to learn from this nivolumab plus ipilimumab study. First, the combination approach had numerically better progression-free survival and overall survival. However, when stratified by PD-L1 status, PD-1 high group did not benefit from combination approach, but perhaps patients who had low PD-L1 were getting benefit from the combination. However, the adverse events were significantly higher with combination, and thus we need better biomarkers to predict the response and to avoid unnecessary side effects. So here, California, San Diego, UCSD, we have Center of Personalized Cancer Therapy under the leadership by Dr. Razel Kurzrock. And really an active collaboration with multiple biotech and pharma, as well as UCSD Supercomputer Center and other basic research labs. To basic research information to clinical care for our patients, our tumor board, which is a key component of this program. And the tumor board recommendation will be applied in the clinic, including our tumor clinic and molecular pathway clinic. We believe the clinical trial approach, which is drug-centric approach as described in this figure, where the same drug regimen based on common feature between patients will not move the oncology field further. So should we design the trial? Consistent drug between patients, which is an old approach, will need to use a consistent strategy, but allowing different drugs based on the molecular profiling results for each patient. And this means we need to do patient-centric trials as opposed to drug-centric trials as described in this figure. So if a patient with, for example, genomic operations in gene A, B, and C, as described in the patient number 1 here, we'll customize the therapy based on those aberrations, potentially with drug A, B, and C. So for patient number 2, who may have aberrations in A, E, and F, in gene A is the same as patient 1, so you may consider the same drug A. This patient will likely need additional therapies that target gene E and F. A number of reports, including from us, suggest molecular matching for patients with customized therapy combination can be efficacious, and prospective study is ongoing with promising preliminary results. A similar approach will be required in the immuno-oncology field. We already know markers associated with response and resistance to the immunotherapy. Some of the markers, as already discussed previously, for the positive response, such as partial or complete response, include positive PD-L1 expression, high mutation burden, microsatellite instability high, and mismatch repair deficiency. Especially with microsatellite instability high, the response can be seen more than 50% of patients across tumor type. There are markers for tumor progression or resistance that includes loss of PAN and activation of Wnt beta-catenin pathway that are associated with decreased T-cell infiltration, leading to primary resistance from checkpoint inhibitors, such as deletion of beta-2 microglobulin or inactivating JAK1 or 2 mutations that impair T-cell immune response have been associated with acquired resistance. There's a new phenomenon that has recently recognized called hyperprogression, where it appears to have paradoxically rapid progression with checkpoint inhibitors that are reported to be seen in about 5 to 9% of patients. The mechanism is unclear, and other groups have identified MDM2 and 4 amplifications as well as EGFR alterations were associated with hyperprogression. Clinical outcome with immunotherapies, not only the genomic biomarkers, but also in-depth understanding of the cancer immunity cycle for each patient will be essential. It is being scoped to go over the cancer immunity cycle in detail, but as Dr. Morrison mentioned earlier, there are multiple targets that are potentially druggable. This note was by Blank et al. As cancer immunogram, a comprehensive understanding of multiple factors, including tumor mutation load, status, immune filtration, status of soluble inhibitors, and tumor metabolism for each patient will be critical for the personalized immunotherapy approach. Now here a bit, and present a couple cases that we are trying to apply the customized immunotherapy approach. This is a 60-year-old man with metastatic anaplastic thyroid cancer. As you know, anaplastic thyroid cancer is one of the most aggressive cancers and no effective therapy. The patient unfortunately progressed rapidly on 2 different therapies and admitted to ICU due to progressive respiratory failure that required intubation and was on ventilator. We recommended hospice for comfort care. However, the patient's family was very supportive and asked us to proceed whatever option the patient may have. The patient was also motivated despite being on ventilator. Along the workup, we found the patient had BRAF V600E mutation and also found that PD-L1 expressed highly positive. For these reasons, we proposed and started him on BRAF inhibitor, in combination with PD-1 inhibitor, nivolumab, while he was in the ICU and on a ventilator. Patient did very well on this combination. Upon he was off the ventilator and started physical therapy. 3 months later, he was discharged from the hospital. We saw the clinic 5 months after the initiation of therapy, and everyone's surprised, patient drove himself to the clinic that took him about a couple hours. In the scan response, as you can see here, the figure shows the CT scan before the therapy. He had a large amount of fluid, which is indicated in circle, and mass in the lung, which is indicated with arrow. He has lymph node, which is showing the left lower figure. 5 months, the fluid diminished, and the mass in the lung and lymph node subsided. Paid well to date. If he is progressing with current therapy, what should we consider? No immune marker came back that both OX40 and CD40 ligand was low. Although not clear, it is possible we can potentially consider a clinical trial that targets these markers in the future. In the end, IO1 was very low, suggesting there's likely no benefit from IDO1 inhibitor. Second case, difficult case, was metastatic cardiac sarcoma. We OmniSeq panel and report was essentially showing the path of immune desert. Except one, which was adenosine A2A receptor, show high positivity. The They're currently seeking clinical trial options that target this receptor. The immunology field is rapidly growing. To improve the anti-cancer effect and to avoid the unnecessary side effects, permanent section of immunotherapies based on the biomarkers are likely required. Addition of response markers are actively ongoing. Further immunotherapy combination trials based on biomarkers are urgently needed. For your attention.
Okay. To attendees, you may take a question at any time. You can do the control panel, which usually appears on the right side of your screen. Before the Q&A portion of the webinar, we'd like attendees to take a moment to exit survey after the webinar has ended to get your feedback. We'll now Q&A portion of the webinar with a question for Carl Morrison. You mentioned clinical utility. Do you agree that there is enough clinical utility to reimburse for the complete immune report card?
I never agree that you have enough clinical utility. That's just the basis of it. But we have some clinical utility, and we're beginning a prospective clinical trial, an institutional prospective clinical trial at the first of the year to support more information interim. Right. Do bill payers for immune report card, OmniSeq comprehensive, and we have a financial assistance plan when patients are denied treatment. But yet there is always an ongoing burgeoning need to do more for clinical utility.
Question for all panelists. Standard practice for NGS testing reports to include immunotherapies represented by incidental biomarkers from testing or the pathology report.
Funding on comprehensive genomic profiling is defined by that list of the ACG put forward. It's standard. And comprehensive immune profiling, well, I think we're the only lab that's out there doing it today. We really don't have a list of incidental findings for immunotherapy.
Want to comment on that question? The next question is for Shumei. One patient was the second profiling low OX40 CD40 ID1 done with the original sample, or was it the post biopsy? Was expression pattern affected by the treatment?
I thank you for this question. I think the question is, was the OmniSeq panel run before the immunotherapy or after the immunotherapy? And the answer is before the immunotherapy.
Yes, that's correct.
Question, the analysis was run using the original sample.
Let me reiterate, and then one of our sample requirements is that the sample taken prior to any immunotherapy. Although one could envision that there would be a need and a reason to evaluate a patient after they failed PD-1 axis inhibition, because there is the possibility that something like CD40 or OX40 could change after a patient has failed a round of immunotherapy. So I expect we'll be seeing that in the future.
The next question is also for Shumei Kato. How the OmniSeq immune report card help you make the clinical decision for a melanoma patient? What information did you use other than the PD-1 expression level?
For this question, actually, I don't practice melanoma, but I do see a wide variety of cancer patients because I do have something called rare tumor clinic. To answer the question, how I'm going to use the OmniSeq report card, that's a very good question. I think I would say we're still learning. we don't typically we don't know how to use the report card. However, I think move on. I think we will use this result to decide which immunotherapy trial patient may potentially benefit. As I mentioned, there are so many immunotherapy combination trials, and we actually don't know which one to choose. So, probably, our hope is that with a OmniSeq immune report card, may be able to choose which clinical trial to move on for the patients. And again, I don't know if that's the right way to go, but I think it makes sense to use this to use this information to move forward.
This question is for Marcia Eisenberg. Marcia, physicians order PD-L1 testing and then reflex to a test like immune report card, or should they order immune report card up front?
Thanks for the question. Well, we've shown today that PD-L1 is a good assay. We've also talked about and shown that there's value in measuring additional biomarkers beyond PD-L1. So we would view that the immune report card should be ordered at the same time. And the strongest arguments for doing that is that over 50% of the immunotherapy clinical trials exclude patients that have had previous treatment. So it would be best to get all of the information that could be gained up front.
Thank you. The next question is for Carl or Shumei. I plan to validate the OmniSeq and report card in clinical trials. Do you think it will be a challenge for a complex composite biomarker scoring such as this?
This is Carl. I'll take the first crack at that. I think many needs in immunotherapy. I think to that, it's even disease type specific, is answering very specific clinical questions. Like Dr. Kato presented right, is can we do a better job of predicting who's going to respond to IPI plus Nivo, Verzo, or Pembro as a single agent? I think we're working on very hard. There's like non-small cell lung cancer. You know, if you round and do the denominator of the prevalence of PD-L1 and treatment, there are patients that respond to second-line therapy, Pembro and lung cancer, than there are first-line. And find those patients and move them to first-line therapy is a very important question. Thinking about, can you just overall predict response to checkpoint inhibitors? And then most importantly, and I think the one that Dr. Kato really emphasized, right, was selection of the correct combination immunotherapy, but I'll let him respond to that.
Yeah, Dr. Morrison's comment, I think the time, over the time, I strongly believe the trend will be to select patients for each clinical trial based on this type of similar assay like OmniSeq immune report card. We already know from a genomic field trying to match genomic alterations based patient for each patient. If you give targeted therapy randomly to the patients, the response is only 5% according to the meta-analysis. The response can be more than 40% if you match the patient with a genomically matched with the targeted therapies. I believe the same thing will happen in the immuno-oncology field with a rapid growing number of targets. At this moment, we are not selecting the patients, but I think the field will be in that direction.
This question is for Carl. We know that RNA expression levels correlate with protein expression levels.
Constellation of immune report card, we chose a few key genes like CD3 and CD8 and PD-1. And we did with samples that had been previously had whole exome sequencing performed at TCGA. So we compare RNA-seq levels to level. Then we performed immunohistochemistry for those markers. With the immunohistochemistry, we had subjective evaluation by pathologists, and then we did image analysis on the PERIO platform and compared the expressed values by RNA-seq analysis to the image analysis values and to the pathologist association. And concordance across those was very good. For CD3 and 8, we were trying to do quantitative concordance, in other words, count the number of TILs per square milliliter of tissue. And PD1, we were really trying to correlate the expression levels measured by IHC by pathologists to what was occurred at RNA-seq. So you do that. We did not do that for every gene because genes like CTLA4, you cannot find an antibody that works. Then you find other genes like FOXP3. When you start doing that, and you start really looking, many cases of very high FOXP3 staining. When you go to look at those, it's not the immune cells, it's the neoplastic cell staining. So there's a lot of intricacies around that, but the most straightforward ones like CD3 and CD8 and PD-L1 did concur that there was an association between expression and RNA-seq levels.
Question is for Marcia. In your experience, how long does it take to deliver a report after the test is ordered?
I think I may need to defer to Carl for that, since this would be reports coming out of OmniSeq.
So, comprehensive and imaging report card are run twice a week in the laboratory. So, if you have a sample on a Monday, it's sent out by Friday. If we receive it on a Thursday or Friday, it's sent out by the following Monday or Tuesday. So, it's a 5-day turnaround time in the laboratory. What we typically see out there, right, is it takes longer to get the sample from what pathology laboratory it exists, some archival forensic pathology sample that's sitting in the bed of some pathology department. Typically, that can take, up to a week to get a sample to our laboratory. Overall, our goal always is to have a sample signed out in 10 days or less, marking at least 90% of the samples.
Thank you. The next question is for Shumei. I treat a patient with multiple overexpressed secondary markers. How do you choose between clinical trials?
Let me think. Multiple overexpressed markers, like immune markers. So really great question. Actually, we don't know, especially for the immune markers. Perhaps we know to some extent for the genomic markers. For example, if the patient do have, say, EGFR mutation that's very actionable and has TP53 and say ARID1A, that's not really, those two are really actionable, then I may go after the EGFR. I think for the markers that we are learning, we will learn which markers are more predictive, or the other marker may be less predictive as a marker. So over time, I think we'll learn those more in the future. Hope I answered the question.
This concludes the Q&A portion of the webinar. We'd like to thank our sponsor, OmniSeq, and our presenters, Marcia Eisenberg of LabCorp, Morrison of OmniSeq, and Shumei Kato of UC San Diego. If we didn't have time to get to your questions, we will try to have our panelists answer them directly afterward. As a reminder, please look out for the pop-up survey from the sponsor after you log out. If you missed any part of this webinar or wish to listen to it again, a link to an archived version will be emailed to attendees. Thanks for joining us for this Genome webinar.